So welcome back to our last hypoglycemia series, hypoglycemia in non-diabetic patient. So hypoglycemia in non-diabetic patient is often unexpected, which makes confirmation essential. So we go back to Dr. Alan Whipple, who established the famous triad to define true hypoglycemia: the presence of symptoms of low blood sugar, documented low plasma glucose, and relief of those symptoms after glucose administration. Now, he developed this framework from his observations in a patient with insulinoma who experienced spontaneous hypoglycemia despite not having diabetes, and it remains the standard for diagnosis today. Now, spontaneous hypoglycemia in individuals without diabetes is rare and often poses a diagnostic challenge. So therefore, careful evaluation is crucial to differentiate true hypoglycemia from other conditions that mimic its symptoms. So symptoms associated with hypoglycemia, as a review, hypoglycemia symptoms are divided into two main groups. Neurogenic or autonomic symptoms arise from the activation of sympathoadrenal system and include palpitation, tremors, anxiety, sweating, hunger, and tingling sensations. While neuroglycopenic symptoms occurs when the brain is deprived of glucose, leading to weakness, fatigue, confusion, abnormal behavior, seizures, focal neurological deficit, and coma in severe cases. As highlighted in our previous discussion, autonomic symptoms serve as the body's early warning signals, while neuroglycopenic symptoms indicate direct impairment of brain function. In 2009, the Endocrine Society released clinical practice guidelines for evaluating and managing adult hypoglycemia, covering hypoglycemia in both with or without diabetes, including spontaneous episodes. In this presentation, I will just focus only on non-diabetic hypoglycemia. But let's begin with the physiology and pathophysiology of hypoglycemia, especially spontaneous hypoglycemia in non-DM patients. The brain relies almost entirely on circulating glucose, requiring a continuous supply to function. Counter-regulatory defenses reduce insulin, increase glucagon or epinephrine, and later cortisol and growth hormone normally prevent or correct hypoglycemia. Symptoms typically appear around 55 milligrams per deciliter or 3.0 millimoles per liter, prompting food intake. At this level, insulin secretion is nearly completely suppressed. Insulin falls below 3 microunit per ml, C-peptide below 0.6 nanogram per millimeter, and proinsulin below 5 picomole per liter. Hypoglycemia develops when glucose used by the brain, red cells, renal medulla, and muscle exceeds delivery from food intake or hepatic or renal production, usually due to insufficient endogenous glucose production or a mismatch with high utilization. So therefore, hypoglycemia arises when glucose demand exceeds supply, counter-regulatory defenses falter, and the brain initiate a rescue response. The evaluation and management of hypoglycemia in adults without diabetes by the Endocrine Society Clinical Practice Guideline in 2009, there are 6 key recommendations that are outlined as follows. Number 1, evaluation of hypoglycemia should begin only when Whipple's triad is documented. The next step is to review history, physical examination, and laboratory findings for possible causes. If the diagnosis remains unclear, testing is performed during an episode or recreated under supervision. When endogenous hyperinsulinemia is established, efforts are directed towards localizing an insulinoma. Finally, treatment is individualized based on the specific disorder, patient burden, and preferences. Now, the general differential diagnosis, hypoglycemia in adult, etiologies by clinical context by Cryer et al. In 2009, classify hypoglycemia causes based on whether the patient appears ill or well. In ill or medicated individuals, hypoglycemia often stems from drugs like insulin, alcohol, and others. Critical illness such as liver, kidney, or heart failure, sepsis, or malnutrition. Hormone deficiencies like cortisol, glucagon, epinephrine, or non-islet cell tumors. In seemingly well individual, causes include endogenous hyperinsulinism, for example, insulinoma, nesidioblastosis, post-bypass hypoglycemia, autoimmune form, and surreptitious or accidental drug use, and certain drugs that may be associated with hypoglycemia even in non-DM patients. Now, here are the list of several non-diabetic agents that can cause hypoglycemia to a different mechanism. These include medication like endomethacin, fluoroquinolones, pentamidine, quinine, and silbenzolin, all affecting insulin release or beta cell function. Now, glucagon may cause rebound hypoglycemia, and unripe ackee fruit leads to toxic inhibition of glucose production known as Jamaican vomiting sickness. Unripe ackee fruit contain hypoglycin A that blocks enzyme needed for gluconeogenesis and fatty acid oxidation. And Cryer and colleague, again in 2009 guideline, also emphasized that hypoglycemia in adult can be classified by context and timing. In ill or medicated patient, it usually arises from drugs, organ failure, sepsis, hormone deficiencies, or tumors. While in seemingly well individual, it is more often due to endogenous hyperinsulinism or surreptitious drug use. This what we mentioned in the previous slide. Timing further defined the diagnosis. Fasting hypoglycemia follows prolonged fasting and is linked to systemic illness, hormone deficiency, or insulinoma. Whereas postprandial hypoglycemia occurs within 4 hours of eating and is associated with beta cell disorder, post-gastric bypass, or autoimmune syndromes. Together, this perspective provides a systematic framework for evaluating and managing hypoglycemia in non-DM adults. Now, when we classify hypoglycemia disorder, there are 3 key perspectives to keep in mind. First, we look at timing, whether the episode occurs during fasting or after a meal. Second, we consider the patient's overall appearance. Are they seemingly healthy or do they look ill with an underlying condition? And the third one is we examine the mechanism. Is the hypoglycemia driven by excess insulin or by a low insulin level due to another cause? Together, these dimensions guide us towards the right diagnosis and management. Now, fasting hypoglycemia can arise from several different causes. Certain medications such as aspirin, sulfa drugs, pentamidine, and quinine are well-recognized triggers. Alcohol binge drinking is another important factor as it interferes with glucose production. Serious illnesses including renal or liver failure can also lead to low blood sugar. Hormonal deficiencies, particularly involving the adrenal and pituitary gland, reduce counter-regulatory defenses. Finally, neuroendocrine tumors such as insulin-secreting tumors or those producing insulin growth factor 2 can drive persistent hypoglycemia. Now, reactive hypoglycemic include the following features. Postprandial or reactive hypoglycemia is more commonly seen in people who are overweight or obese and have insulin resistance. It can often serve as an early warning sign, a frequent precursor of type 2 DM. The risk is even higher in those with a family history of diabetes or insulin resistance syndromes, making careful monitoring and lifestyle interventions especially important. When evaluating hypoglycemia in adults without diabetes, as outlined in the recent 2025 journal article, Non-Diabetic Hypoglycemia Evaluation and Management in Adults by Eugene Loe and co-workers. It begins with a thorough history and physical examination followed by confirmation of Whipple's triad. If the triad isn't met, we considered mimics such as dumping syndrome, idiopathic postprandial symptoms, or other conditions like anxiety and hyperthyroidism. If Whipple's triad is confirmed, we assess whether the patient appears ill or well. Ill-appearing patient may have hypoglycemia due to critical illness, organ failure, malnutrition, adrenal insufficiency, or alcohol-related causes. For well-appearing patient, we obtain laboratory during and hypoglycemic episodes including glucose, insulin C-peptide, proinsulin, beta-hydroxybutyrate, and sulfonylureas screen. This helps us distinguish between insulin-mediated and non-insulin-mediated causes. Now, high insulin level points to either endogenous sources like insulinoma, non-insulinoma, pancreatogenous hypoglycemia or NIPHS, or autoimmune syndrome, or exogenous sources such as factitious insulin use. Now, low insulin level, on the other hand, suggests non-islet cell tumors or other metabolic causes. This structured approach guides us towards accurate diagnosis and appropriate management. Now, NIPHS or non-insulin pancreatogenous hypoglycemia is a rare condition distinct from nesidioblastosis or islet hypertrophy, marked by exaggerated insulin release after meals. Patients present with postprandial hypoglycemia while the 72 hours fast is usually negative. Diagnosis is required ruling out insulinoma with newer imaging like exendin-4 PET or CTs showing multifocal pancreatic involvement. Management includes dietary changes. Medications such as acarbose or diazepam may help, and in severe refractory cases, partial pancreatectomy may be done. So, nesidioblastosis is an uncommon pancreatic disorder marked by diffuse hyperplasia and hypertrophy of insulin-secreting beta cells. This abnormal growth results in an inappropriate insulin release and recurrent hypoglycemia. It presents in infant as a congenital condition and more rarely in adult, often after bariatric surgery, where chronic incretin exposure, particularly GLP-1, may drive these changes. Histologic examinations show enlarged islets, dactylo-insular complexes, and beta cell budding from ducts. The diagnosis is established when hypoglycemia with hyperinsulinism occurs in the absence of an insulinoma with confirmation by pathology. The management typically begins with dietary and pharmacologic measures, though partial pancreatectomy may be necessary in resistant cases. Crucially, nesidioblastosis is not a neuroendocrine tumor like insulinoma. The key distinction is that NIPHS refers to clinical syndrome while nesidioblastosis describes the underlying pathology. Now, let's go now to insulin autoimmune syndrome. Again, it's a rare cause of hypoglycemia often triggered by viral infection or medication like methimazole or alpha-lipoic acid. It involves insulin autoantibodies that bind insulin after meals, initially causing hyperglycemia. But later, these complexes break apart, releasing free insulin and leading to delayed hypoglycemia. Patients typically present with postprandial symptoms and an extremely high insulin level. Most cases resolve spontaneously, but severe episodes may require dietary changes or even immunosuppressive therapy. Now, the non-islet cell tumor hypoglycemia, or the NICTH, is a rare cause of fasting hypoglycemia driven by excess production of big insulin growth factor 2 from solid tumors like hepatocellular carcinoma or stomach cancer. This modified IGF-2 increases glucose uptake and suppresses hepatic glucose output, leading to low blood sugar. Laboratory findings show low insulin, C-peptide, and ketones with an elevated IGF-2 to IGF-1 ratio, typically above 20. The management focuses on the tumor resection and glucocorticoid, which help restore glucose level. Newer therapies like PI3K inhibitors and protease inhibitors may also help by reducing glucose uptake. Now, this table helps us differentiate the cause of elevated insulin level in hypoglycemic patients by analyzing 5 key markers: insulin, C-peptide, proinsulin, sulfonylurea, and insulin antibodies. In exogenous insulin use, insulin is high but C-peptide and proinsulin are low because the body isn't making insulin, it's being injected. Sulfonylurea and insulin antibodies are negative. In insulinoma, all 3 markers, insulin, C-peptide, and proinsulin, are elevated, reflecting autonomous secretion from pancreatic tumor. Sulfonylureas and antibodies are absent. In sulfonylurea-induced hypoglycemia, insulin, C-peptide, and proinsulin are also elevated, but sulfonylurea is positive, confirming drug-induced stimulation of endogenous insulin. And lastly, in autoimmune hypoglycemia, insulin, C-peptide, and proinsulin are elevated. Sulfonylurea is negative, but insulin antibodies are positive, pointing to antibody-mediated insulin dysregulation. So, spontaneous hypoglycemia can arise from several distinct conditions, each with unique biochemical profile. Insulinoma and NIPHS show elevated insulin, C-peptide, and proinsulin with negative antibodies, indicating endogenous secretion. Exogenous insulin use presence with high insulin but low C-peptide and proinsulin, since the insulin is injected. The autoimmune hypoglycemia mimics insulinoma biochemically but includes positive insulin antibodies. In contrast, IGF-mediated hypoglycemia shows low insulin markers and no antibodies, pointing to a non-insulin mechanism. Laboratory interpretation in hypoglycemia relies on key markers measured during an episode. Low insulin, C-peptide, and proinsulin suggest non-insulin or IGF-mediated causes. Elevated insulin with low C-peptide points to exogenous insulin use, while high level of all 3 indicates endogenous hyperinsulinism such as insulinoma or NIPHS. The presence of oral hypoglycemic or insulin antibodies help identify drug-induced or autoimmune hypoglycemia. Now, beta-hydroxybutyrate and glucagon response further clarify the mechanism. So, in summary, diagnosing hypoglycemic disorder in non-DM patients demands strong clinical suspicion. thorough assessment, and systemic evaluation guided by established criteria. The first step is to review history, physical examination, and laboratory data for clues such as medications, critical illness, hormonal deficiencies, or non-islet cell tumors. In otherwise healthy individuals, the differential diagnosis narrows to drug-induced hypoglycemia, accidental or intentional hypoglycemia, endogenous hyperinsulinism, and idiopathic postprandial hypoglycemia. So with that, I will close my 6-part hypoglycemia series, and thank you again for listening.